Hi, everybody, and welcome to the latest in the series of the RCGP live events. I'm Martin Marshall, I'm Chair of the Royal College of GPs, and I'm a GP in Newham in East London. Thanks so much for joining at what is, I guess, the busiest time of the year, maybe. 3 days away from Christmas, you had a choice. You could either go to a wild festive party, or you could come to a work-related webinar on Omicron, and I'm confident that you've made the right choice. I'm absolutely delighted to be joined by panelists who are at the very centre of the pandemic and the college's response to the pandemic. We've got Chris Whitty with us, hardly needs any introduction, our Chief Medical Officer for England and the most amazing advocate for general practice. We've got Professor David Spiegelhalter from the Winton Centre for Risk and Evidence Communication at the University of Cambridge, also a media star, and I'm sure you've heard a lot of him on the radio and television. We've got Nikki Kanani, Medical Director for Primary Care at NHS England. Nikki, great to have you with us. And we've got Gary Howsam, who's a GP in Cambridgeshire and Vice Chair of the College for External Affairs. I think it's probably fair to say that the last 4 weeks have been rather preoccupied with Omicron for general practice, either directly because GPs have been very involved in the delivery of the vaccine, or indirectly because of the impact on our non-pandemic work. The emergence of the new variant, I guess, was disappointing, just as it felt like things were starting to return to normal, but it was hardly unpredicted, it was expected. Unsurprisingly, GPs have risen to the occasion yet again. And they're doing a tremendous job in contributing both to the vaccine programme and indeed to providing urgent care for our patients. The goodwill is very clear in general practice, though I don't doubt that goodwill is more fragile than it was 18 months, 2 years ago, because people are battle weary and many are quite damaged by what they've been through over the last couple of years, but they're pulling on and pulling through. So tonight we've got an opportunity to hear about the epidemiology, the virology, the public health from Chris, an opportunity to hear a bit about the sociology, the psychology, public understanding from David, an opportunity to hear about the role of NHS England from Nikki and the implications for practice, and a description of what the college is contributing to from Gary. You can put your questions to the panel, please do so, either on hashtag RCGP Live on social media, or if you're watching on YouTube, please post your questions below the feed. Members of the team are going to feed your questions through to me, and I'll then convey them to the panel. This session is being recorded, and so it'll be possible to watch back at a later date. Okay, so before we turn to you for your questions, I just want to ask a few quick questions of our panel members, just to warm them up. So first of all, to Chris. Chris, we're hearing so much from many different epidemiologists, many different virologists about how the pandemic is likely to play out. And we're seeing lots of different predictive models, which are predicting many different possible outcomes. So what's your prediction of what's going to happen over the next few weeks with Omicron? And what are the chances of a new variant hitting us at some time in the near future?
Thanks very much indeed, Martin. And before I start, I mean, I really, really want to say a massive thank you to people for both what they have done and what they are doing on Omicron. What general practice has done over the last 2 years and is continuing to do is absolutely amazing. And I just wanted to be really clear, that is my view. In terms of where we're going to go over the next while, I mean, there are obviously some very important things that we don't know. But there are a couple of things that we do know, which are the reason why we have to respond so rapidly to this variant. The first thing that we do know is that this is spreading not only in people who have not been exposed to the virus and not been vaccinated, but actually spreading to people who've had previous infections and spreading to people who've had 1 or 2 doses of the vaccine previously. And so this means it can spread much more widely through the population than previous variants, which have had a lot of control from prior immunity. So the size of the wave we could get with this is considerably greater in theory than the size of the wave that we could have got with, for example, Delta in theory, because you're not getting that natural check on who it can go to from prior recent infection or prior vaccination. The second thing that we know is that in part because of that, but also in part because it is intrinsically more infectious, that is really clear than previous variants, it is moving at absolutely extraordinary speed. And the doubling time in parts of the UK, this has been less than every 2 days. It's probably running, for the sake of argument, at around every 2 days, maybe extending slightly now because people are being more cautious, particularly in the run up to Christmas, but nevertheless moving incredibly fast. This is faster than any of the previous waves we had. Now, the reason that's important is that we are going to get two things happening in almost simultaneously. The first of which is, and I'm sure all of you will have seen this, because it is spreading so widely through the population, most noticeably in London now, but it's going to be through the rest of the country very shortly, colleagues are going down with COVID simultaneously. So doctors, nurses in all parts, primary care and secondary care, are going down with COVID and having to, are unwell themselves, having to isolate or having to care for others. And so there's going to be a sort of supply side of healthcare problem. And then we're going to get almost immediately after, as we're already beginning to see this in London, we'll begin to see it elsewhere, people going into the health system through primary care and then into secondary care, a wave of hospitalizations and a wave into primary care. And those are going to happen at the same time. And we do not know how high this wave is going to be. And modelling, in my view, it can tell us a theoretical upper limit. What it can't tell us is where this is going to turn over. What we do know, though, you only need to be able to multiply by 2, work out doubling times. And if it's going that fast, you get from very small numbers to very large numbers incredibly fast. So it's the speed this is going at, which is the issue. Now, at a certain point, it will, all waves have a beginning and middle at the end, with the moment, the beginning, the middle is when it peaks, and then it starts to go down, and the cases going to hospital and into primary care are delayed slightly after that. But until we see the peak, we have to assume it's just going to keep on going up. It may slow down, but it'll keep on going up. And we will, with a delay, then see people going into care who need more need hospital or at least general practice primary care with this disease. Obviously, many people won't need to go into bother the doctor to use old parlance, i.e. phone up general practice. They'll just be unwell for a bit and then get better. But some people definitely will at least need your advice, and some will need to go into hospital. So that's the real problem. It's the speed of onset that is the real issue. Obviously, for wider society, there's also lots of other people going to be sick in lots of other parts of society, and that's also going to cause wider issues. And these are going to be obvious, I think, in many parts of the country from certainly the middle of next week and on into January, until such time as the peak occurs. So that, I think, is the principal thing for us really to turn and face. And in terms of could there be another variant? Yes, of course there could. As time goes by, medical science de-risks this. So we will get polyvalent vaccines, we'll get better antivirals and new and more antivirals. We've already got some early ones that look quite promising. So if I look to the long term, whilst new variants will happen, they will cause fewer and fewer problems on average as every 6 months rolls on. And population immunity will gradually build up, and the immune system will start to see different variants of the virus, and that will, over time, take the risk profile down. But we're not going. This is not the last variant we'll see, and this may not be the last significant variant we see. But this is certainly a very concerning one, and principally because of its combination of immune escape and its speed of transmission.
Chris, thank you very much indeed. Just before I come back to you with a second question, Gary, could I turn to you, because we've got some very preliminary, quick and dirty data about staff absences in general practice, which Chris referred to. Could you just give us the headlines very quickly?
Yeah, absolutely. So this was a very quick survey we sent out yesterday to about 200 of our sort of GP leaders that the college has contact with. And the top lines that have come back is saying practices are experiencing high levels of staff off sick, worse than usual, according to 95%. Around 14% of clinical staff and 17% of non-clinical staff are currently off sick. But it's not being felt, as you'd expect, evenly across practices, and 13% of practices reported having between 40 and 60% of their staff off sick overall. So the lack of ability of staff, or availability of staff, and the lack of locum staff to fill those gaps are the things that people have been highlighting in the last 24 hours.
Brilliant. Thanks very much, Gary. And just a quick question to follow up for you, Chris. You and I sent a letter to RCGP members a couple of weeks ago about the need to prioritise the booster campaign and urgent care over routine general practice care. Quite a difficult thing to say, isn't it, to general practice and to patients? Was it an easy thing for you to advise on?
No, because I mean, I think we all recognise that general practices are always stretched at this time of year, badly stretched at this time of year. And this year's even more difficult because you've got a lot of backlog of things from the previous COVID waves that mean that this is busier than an average year by some distance for most practices, as indeed it is actually in secondary care as well. So deviating people away from that part of their work is not something to do lightly. But the reason we thought we absolutely had to do it, and we as a profession have to prioritise this, and the NHS has to prioritise this, is we have a narrow window of opportunity. I think we're now very confident that the booster vaccines work significantly better than the people who've had 2 vaccines. Obviously, any vaccines are better than none for reducing severity, but the booster definitely does. If we can get as much of the population, and particularly the vulnerable population, boosted before the absolute peak of this really hits us, which it is going to very shortly, unless it tops out very quickly, which I think would be very optimistic to assume, then the impact this will have on all areas of the health system and the impact on our patients' health will be substantially lower. So we really had to accelerate getting boosters into people so that actually they are protected before we get to see the worst of this. And in fact, in a sense, it's an investment for the future in terms of the health system, and of course it's a protection for our patients. But it's the speed of this that meant we had to move from what was already a very fast rollout to a one that was going at absolutely astonishing speeds. And if you look at the numbers of vaccines that are being produced, are being given through general practice and through other routes, we knew that without general practice that was not possible, and that if we did not do this as a health service, we would pay a heavy price for it, and more importantly, the population, the vulnerable population, would pay a heavy price for it as we went into the new year. So I'm extraordinarily grateful for people's ability to turn around, even at this incredibly difficult time of year, to meet this new threat. But I think we thought it was absolutely essential we did that.
Chris, thank you very much indeed. Nikki, over to you. Thanks so much for joining, and thank you for the amazing job you're doing as a clinical lead for the vaccination programme in NHS England. I suspect you don't see very much of your family at the moment. I think that's pretty fair to say. But thank you so much for everything you're doing. So, Nikki, how's the booster programme going, and how's the vaccination programme in general going now?
Oh, thanks, Martin. I mean, like Chris, we'll start off by focusing on what general practice has achieved, not just in this accelerated phase, but over the last year. We are just over a year when the first general practice run, PCN run site opened, and it has been phenomenal. You will have felt the energy, we all would have, that ability for general practice to very much come to the rescue after a very difficult year through the pandemic. So huge thanks, first of all, to our teams who have been delivering again and again and again consistently for the last year in the vaccine programme. I thought I might just pick up on a couple of Chris's points about the impact on staff and sort of the wider asks of general practice, because essentially when we had the PM announcement, which rightly said we need to accelerate boosters, this has to be our nationwide priority. We also recognise that this would have a huge impact on staff and staff absence rates. Just to flag, we have sent out some guidance about making sure you're reporting staff sickness, because we really need to know, and local systems need to know, what's happening in primary care so that we can get the right support in place as well, because certainly many of you will be feeling this in London and sort of just out of London. Already we're getting practices with what we would describe as outbreaks, but if we don't have the data, we can't come back and support you. So Gary, that was really useful. Please do keep reporting it into your systems. So if you look at the kind of, take a step back, the wider spectrum of what general practice will be doing over the next few weeks, and we're certainly seeing that already, is doing that really important job of prioritising the booster programme, but also urgent care. So my thanks to the college and BMA for producing some really helpful guidance around workload prioritisation so that practices can safely and confidently focus on the care that needs to be delivered over the coming weeks. As Chris said, this is a urgency that we can't ignore. And I know many of us feel anxious about giving our patients the wider care, but I think what's really clear in the messaging from yourselves, ourselves, government, is the NHS is still open. What we don't want to see is that really steep drop-off of attendance for care that we did in the height of the pandemic, because actually that was really detrimental to both patients' experience of care, but their relationship with their care providers. So general practice is open, but it's focusing on certain elements of care, and you will have seen that through the missives and the messaging that Chris has put out, that PM has, Secretary of State, myself, and through kind of all of our various media opportunities. So where has that got us? Well, a really phenomenal week, you know, up more than 70% on the week before in terms of numbers of boosters delivered. General practice pulling out all the stops to ramp up really from the PM's announcement on Sunday night. By Tuesday, we were seeing the impact in general practice in terms of additional booster delivery. Notably, it was also a bumper day for community pharmacy, who delivered 200,000 vaccines on the Tuesday. So primary care really showing what it's able to do in the booster space. And every day since then has been a bumper day, a record day for boosters, but also for unvaccinated people coming forward. So that's really key from our perspective, making sure that people are at least getting one dose or their second dose if they haven't had those already, and targeting really vulnerable populations. So last week, general practice were particularly focusing on our housebound, our care home staff and residents. I'm very grateful for that. Today, Sharon in Northwest London sent me a picture of a van which had found a number of people who are seeking asylum, got them onto the bus, got them over for their vaccine, offered health checks, and gave Christmas presents to their children as well. That is general practice at its finest, and I'm so very proud to be part of a profession that does that. But that doesn't mean it's easy, right? So all of our colleagues are feeling the pressure at the moment. We're also talking about the need for more assessment of COVID in the community, deployment of virtual ward and pulse oximetry at home, and as Chris mentioned, referrals for monoclonal antibodies and antivirals. So a very big, complex, changing environment at the moment. But I do think that it's really worth reflecting on the incredible work that teams have done. Over the weekend, we delivered 1.5 million booster vaccinations in one weekend alone. I think that's really quite incredible. And every day now, as I said, people are extending, you know, opening 7 days a week, opening 12 hours a day, going roving well into the community to make sure that everybody gets their opportunity. This doesn't happen by accident, and what we really needed is for system partners to support general practice to do this. So from a workforce perspective, releasing additional staff through NHS professionals, the voluntary offers that we have, St John Ambulance, and remembering that clinical and non-clinical staff can be deployed at no charge to primary care network LVSs and community pharmacy LVSs. So there is a pool of money that we've deployed so that you can get additional staffing into your local vaccine service with no additional charge. Last week, we were trying to get supply in the right place, but there is plenty of supply and some really great work from our local pharmacists to make sure that we get the supply into the right place through mutual aid and now through increased volumes of deliveries. Lots happening in the media, Martin, to support the uptake. So you might have seen the Mass Media Monday. So every publication had a booster wrap around it. I was on drive time. We were talking to everybody about the need to have the vaccine before Christmas. Definitely in the last couple of days, people have described a slight drop off, people saying that they don't want to get unwell before Christmas. So anything we can all do in our messaging to make sure that people recognise that, you know, a few hours or a day of side effects from the booster is probably much easier to handle than COVID itself. We've released some top tips about kind of generating demand locally, so particularly by working with your local authority. We've got people who are out flyering their local supermarkets and shopping centres. We've got town criers calling about the booster vaccination and where to get it, and particularly working with local faith and community partners, as many of us have done earlier in the year. Particularly worth flagging that if you are having a slower day, lower footfall, please use those opportunities to vaccinate people with severe mental illness or learning disabilities. That quieter environment tends to be more beneficial for certain of our community, really worth thinking about. And not everyone celebrates Christmas, so being able to rove into communities at a time when some groups who might have not come forward for the vaccine may choose to now is really important. The specific support, Martin, just to finish off, we published a letter on the 7th of December that described a range of contractual measures to support general practice to deliver the vaccine programme. And of course, your very helpful guidance with BMA follows on from that and talks about prioritisation. And we're really clear that we want to support general practice to make the right clinically led decisions, because what we can't do from the centre is decide or define what you're experiencing locally, what your local practice is, what your patient interaction is, what your patient needs, and what your surgery and your workforce needs. So what we clearly say in the letter is we have your back when you're making clinically led decisions, and here is the guidance, of course, that the college and BMA have produced. The Winter Access Fund is still £250 million out in the system. I came and talked about it at the Royal College Conference. It feels a very long time ago now, but you can use that to deploy additional capacity over the Christmas and New Year period. So please do use that as a funding source to draw down on. We've also worked with government departments to do things like extend the fit note period, so we're not spending time signing fit notes, suspend the recertification requirement for existing prescription charges, pause firearm certification, suspend requests for medical information for driver's licenses, suspend friends and family tests, and CQC have also suspended inspections in general practice, including unannounced inspections until the end of the year, unless it is a life or death situation. From a funding perspective, I'm not going to call out the numbers because I know that's not why we're here, but certainly the funding has been increased for vaccines delivered on weekdays and Saturdays, and further increased to cover Sundays and bank holidays, and then further increased to cover the festive period to support all PCN and CP sites, so that we can keep that capacity open. We've also just announced this evening further support for travel and subsistence costs. So if you are open over the festive period and you want to pay travel, I hope you do want to pay travel, and if you want to put on, as somebody described, a buffet for your team, the funding is there for that as well. And then I think the other thing, Martin, you know, the thing that I hear most from colleagues is we just need to have the messaging out there that A, this is what general practice has been asked to do by the Prime Minister, and B, please don't give us a difficult time if that's what we're doing. So we've got a set of campaign resources, both respect materials, how to access general practice, but also the messaging I mentioned up top that CMO Chris, PM Secretary of State, all of our media outlets are focusing on, so that we're clearly saying that general practice has been asked to do this, because you know what, general practice is not just good at delivering volume, but general practice is responsible for making sure that our most vulnerable are protected as well. So look, Martin, I'm always up for suggestions. If there are other things that we need to be doing, really keen to hear, but I'm very proud of our profession for stepping up again. We will develop a longer term infrastructure so that we don't have to keep stepping up, but in the meantime, thank you, and we're here to support you.
Vicky, thanks so much for that comprehensive summary. That's incredibly useful, and what an enormous amount of work NHS England is doing to support this programme. So thank you for that. David, I'm going to turn to you. The pandemic really has shone a light on our capacity to deal with uncertainty, and I clinicians, but certainly the public and journalists as well. What have you learned about how the public responds to risk, and what are you seeing in terms of kind of the public's response and how we deal with it, particularly around things like vaccine hesitancy?
Okay, thank you very much. And I've also got to say that I'm really humbled by the amazing work being done by GPs in particular. I've got a GP in my family, and I know the stress that she's been under, and this booster campaign only goes on top of it. I've also got to say I'm hugely impressed at the work being done by the analysts behind the scenes, analysing all the data. As a statistician, I would say that, because there's never been such attention to numbers. I don't know what Chris feels, but I'm not sure if there's been a time, maybe back last March, but March last year, when every day the numbers are being very important. And there's actually widespread misunderstanding. The Telegraph has just written, latest data from the UK Health Security Agency shows that more than 106,000 people tested positive for the virus in the last 24 hours. No, they didn't. That is just not what that daily number means. It's reported. Some of those will have been tested positive a week ago. In fact, if you look at the days on which specimens were actually taken, there are 103,000 tested positive a week ago on the 15th. So, again, it's just unbelievable, the lack of basic understanding of some people in the media of what these numbers actually mean. And yet people take a lot of interest in these. I mean, some journalists have done a fantastic job, but it really makes me want to feel like banging my head against the wall. In terms of risk, risk is really complicated, really difficult. And people say there's sort of risk as analysis. There's all the numbers, the benefits and harms of vaccines, the effectiveness, the vaccine effectiveness, and so on. There's all those numbers we're hearing all the time. But basically, we know that mainly risk is a feeling. We respond to things emotionally. And that works fine most of the time. But sometimes it's like the thinking fast and slow idea. We really should encourage others and encourage ourselves to calm down and cool it and think slowly, cold towel on the head, and just think, okay, what are the benefits and harms of different interventions? And this comes, into our work on vaccine hesitancy, which we work on communication with a gang of psychologists, and we know, I should say, my unofficially adopted daughter, GP, is in the Black African community. And we talk a lot about the hesitancy in that particular community about vaccines among her family and others. So, I know a bit about this. And it is a real problem because of this lack of trust in science, even in authority, and so on. So how does one deal with that? Well, we've kind of been exploring different ways of communicating. And if you look at the government website on the vaccine, it's good stuff, but it's terribly persuasive. It really is hammering through, but you've got to get the vaccines are great and the minimal side effects, blah, blah, blah. There is another way to communicate, which is to do with really trying to inform people rather than trying to persuade them, which is actually acknowledging that wherever you do, there's benefits and harms. And that's true of all medical interventions. And so we've been actually doing experiments where we give one group of people the standard government stuff on the government website, and another group of people one that's been edited to include more information about the side effects, to actually talk about the quality of underlying evidence, but also to pre-bunk misinformation, to get in there and hard pre-bunk misinformation. And we randomly allocate people to get these two versions. And we found that overall, their trust in the information, if you average over everybody, isn't very different between the two. But if you look at the subgroup of people who were initially skeptical about vaccines, their trust in the information goes up with the more balanced version rather than the government version. And we don't know whether we can't translate and say, well, that will make them more likely to take the vaccine. But I think this adds to a growing body of evidence that one strategy for countering hesitancy is to actually be more open. You've got to demonstrate trustworthiness. In the end, I don't think you're ever going to convince anybody by facts alone. It will come from trusted messengers and by people feeling that you have the communicator has their interests at heart. But what this has shown, we again and again in experiments showing that actually being very open about the fact that, yeah, there are some side effects in these things. They're very small compared with the benefits, and so on, does not reduce trust in the information source. So I think that's really quite important. Martin, do you want me to just talk about the off-the-press data about the benefit, the relative severity of the variants? I think it is quite interesting.
That'd be brilliant, David. Yes, please.
So the Scottish study, the South African study came out yesterday. The Scottish study came out at 4 o'clock this afternoon. The Imperial and UKHSA study came out at 6:05, I think. So we're being hammered by data. Broadly, the South African one, which is in a very different context, showed that 80% reduced risk of Omicron compared with Delta, but that, I think, one has to take with a huge pinch of salt. The Scottish study was small, showed a 2/3 reduction risk reduction of hospitalization of Omicron compared with Delta. Much better, really good quality study, I think, but quite small. It just said out of 22,000 Omicron cases, we'd have expected 47 hospitalizations. We actually only observed 15. Very encouraging, but as you can imagine, a lot of uncertainty about that figure. The Imperial study just come out is based on a much larger data set, and they show if you count hospitalization as at least 1 day and actually being coded as admitted, 45–50% reduction in risk from Omicron compared with Delta. And so, which is encouraging. Perhaps, it'd be nice if it's even bigger, but it is encouraging. But they do also show the huge increase in reinfection risk, but also that if you, let me find some great information. The great thing about if you catch Omicron after you've been infected, there's 60–70% reduction in risk of hospitalization compared with if you've never been infected. So there's some quite positive data here that doubtless, and Chris would know about this, is now currently being included in all the models to adjust the projections under different strategies. It's a very closely balanced thing, but crucially, if we're thinking into the new year, it's the booster program that is going to be the absolutely vital element. Okay.
David, thank you so much. So you've answered one of the questions that has come in from a member of our audience, from Chris Bronsden, about the latest research. I have to say that I wasn't aware of the results of the research that's been published in the last 45 minutes, but David, you were, and I'm very grateful to you for that. So talk about hot off the press. That's really impressive. So before we open up for other questions, let me just turn to Gary very quickly. Gary, you've been leading the college's work on workload prioritisation, working with our colleagues in the General Practitioners Committee of the BMA. Do you want to give us a quick summary on what it shows?
Yeah, of course, and thank you, Martin. So we produced over the course of the pandemic several iterations of our guide to help with workload prioritisation. Which has been something that our members have been asking for, and we've had good feedback on, because I think as we've gone through various phases, whether that's acute waves, whether it's vaccine booster pushes, or whether it's just been playing catch up, the last 21 months have been phenomenally difficult in general practice. And we've heard people saying thank you for the efforts over the last 10 days, but I think we just want to reflect on, it's been a slog for 21 months now, and we knew when we got asked this time again to pivot our focus onto the booster vaccine campaign that we can't do everything. We've got incredibly tired teams now. People are psychologically tired, they're physically tired, and there's only so many hours in the day, even if you're working all your days off. So what we've done this time is produce another document. I'll start by saying what it isn't. What it isn't is a replacement for expert clinical judgment. And what it can't do is take into account those very local factors around the states, your staff makeup, the demographic of your population. But it's a document that needs to be read by GPs, and it needs to be supported by local commissioners. And it needs to allow us to focus on where we can add most clinical value. We've not produced a list of things that we think should be turned off. And we've not produced a list of things that we say absolutely must continue. But what we've done is highlighted things that we think are a current clinical priority, even with everything else we're being asked to do. And those things that we think it's safe for people to put on pause, recognizing that we're not actually stopping anything, we're just shifting work. And that when the applause for the booster campaign dies down again, we'll be playing catch up, and our teams will be working incredibly hard. So this is a document to facilitate local conversations, and we published the latest version yesterday. And if I can just highlight one thing that's in there that wasn't in there before, is a link at the bottom of page 2 to a document on business continuity, which may be something we'll pick up later, but it's just a link to a 1-hour checker which highlights the sort of things that people should be thinking about in terms of business continuity, when we know that when the wave hits, if we're losing staff, we're in a bit of a perfect storm. But that's the summary of it. It's all available on our website. If you just Google RCGP workload prioritisation, it'll take people to the link. It's very self-explanatory, and hopefully it will provide the sort of support that people are looking for on the ground, where they're at the really sharp end, where they're feeling crunch.
Gary, thank you very much indeed. That's really helpful. So, so if you're a GP, do have a look at that guidance. I hope it's useful to you, and do feedback if you've got any suggestions. I'm going to move to questions from the audience now. Before I do that, I just have to tell everybody that Nikki has had to drop off. One of the joys and challenges of working with a top panel is they get called out at very short notice to do important things. So Nikki's just had to disappear. I'm not sure if she's going to be able to come back. But let's look at some of the questions from the audience. So one from, where are we now? One from Ben Cotton. For you, Chris, I think probably. How quickly do we think we'll see the benefit of the booster? Indeed, have we already? How quickly will we see it? And then I think a link question from Flint Dog One, whoever Flint Dog One is, says, are there any vaccines near to launch that will offer a much longer benefit than the mRNA ones? Chris.
Thanks very much. I mean, on the first one, there's a individual level answer and there's a population level answer. For individuals, I think that you get a faster response to a boost than you do to the very first time you see a vaccine. So I think people are beginning to get some protection even within 7 days, probably, but actually it'll then rise, and by 2 weeks you'll have quite significantly better protection than you had before you were boosted. So it's relatively fast. It's not immediate, of course, and that's something we do need to remind people that they can't just have their booster and then go straight off to the nightclub. There is going to be a period of development. At a population level, I think we are already seeing it, actually. I think that we will probably see many fewer older people in hospital and coming into general practice because the boosting program has already gone through that age group to a very large extent. And once the whole population is boosted, then we would expect to see a reduction, a slowing down of transmission as well, because we think that it'll probably, once you're boosted, as opposed to people who've only had 2 vaccines, where it doesn't make much difference, it's likely, not definite, but likely it'll slow down transmission as well. So there's kind of 3 levels of benefit, but as I say, at an individual level, you can reassure people that they, whilst they won't get immediate response, they should start to see what they won't see, but they will get significantly increased responses probably from a week and definitely from 2. In terms of new vaccines coming through, there's a lot of new vaccines kind of just on the edge, really. Some of them are new types, like the Novavax vaccine, which is a protein-based vaccine, and that may have some advantages. And that's is likely to be licensed very soon, I think. And then some of them are older in the sense of older for this pandemic, still very new vaccines like the RNA ones, where we're going to have either polyvalent or bivalent vaccines where they actually cover more than one variant, or we may have Omicron-specific vaccines. And I think they will be available probably within a few months. Now, we'll then need to make a decision as to which are the right ones to deploy. And the reason that we would expect them to be help protect for longer are twofold. I mean, the first thing is it maintains protection in the individual just with this, against the same number of viruses. And in the case of the polyvalent vaccines in particular, it also may broaden that protection so that if a new variant comes along, back to Martin's second question to me, it is less likely to cause havoc in the way that Omicron is causing at the moment. So I think those will be solid improvements, and we'll then need to really work out what is the kind of routine we're going to go through. How often do we need to reboost particularly vulnerable people to maintain their level of protection, and then also when do we need to reboost to meet a new variant? And I think we'll just, we're in the foothills of our understanding of this, but they will definitely, our understanding will improve over the next 6 months to 12 months.
And dare I ask, Chris, for your prediction of that? I guess we all hope that that the COVID vaccine might be for life or might be for 10 years like Hep B. But of course it wouldn't be. Then we hoped it might be for a year like flu. Any idea of where we're going here?
I think it's, so I don't think it's likely to be for life. I mean, I think that's pretty clear now. But I think once people have been shown the shown the antigen via vaccine plus minus infection several times, the immune system kind of wises up. And so we may well be able to drop down to less frequent runs through, except when there's new variants, or in the very vulnerable populations. But that's not having to do whole populations in the kind of way we are at the moment. But I wouldn't like to predict a number at this stage. I think it's too early to be confident.
David, how would you predict how the public will respond to the frequency of vaccinations? What is their tolerance for engaging with COVID?
Don't ask me. I'm sorry. I'm a statistician. I'm not a social psychologist or whatever. It's just, in my observation, that the one thing that does always, I think, surprise me is in the surveys is just how not only tolerant but supportive of the population, or the majority of the population, are for very strict measures. That always is a regular finding of that support. Now, how that translates into attitudes to repeat vaccination and other things, there does seem to be, there's a lot of concern, a lot of fear and anxiety in society, clearly, and although there's also communities that have got very different views, the majority view seems to be that of adhering to measures, of supporting stronger measures, and as we've seen, getting vaccinated.
Indeed. Gary, we've got a question from Ashley Liston. Is there a role for recently retired GPs during the potential workforce stresses? Not just GPs, I guess, all clinicians? And if so, can the performers list bureaucracy be reduced? We've got a group in our college for late career and retired medics. And Ashley points out that they have made offers quite consistently over the last 18 months or 2 years, but often those offers haven't been taken up.
Yeah, thank you, Martin. And that's a great question, Ashley. And I think one of the frustrations that we're all feeling on the front line is when we've got recently retired colleagues saying that they're willing to come back and help, and they can't facilitate that. We've actually got my old senior partner who's been retired for a few years now, jabbing in our practice for the last couple of days. So people can be onboarded at short notice, but it's really important that we expand the workforce in any which way we can at the moment, whether that's to support the booster campaign, whether that's to support business as usual. And obviously recently retired members have got a wealth of experience that they can contribute to the effort. And one of the college's main policy aims over the last 2 years has been to reduce bureaucracy of all sorts, because we know it has a detrimental impact on both workforce, but more importantly on the workload as well. And at a time like this, when we really need every clinician that can contributing in the way to add most value, then if it's purely bureaucracy that's getting in the way, then that's a shame. And we're doing everything we can at the college to make sure that those barriers are removed. And I just suggest, if there are people out there who are recently retired, I know certainly within my CCG, they're collating lists of people who both need additional staff and additional staff offering their services, and they can often help with the bureaucratic processes to speed them through.
Thank you very much, Gary. We've got some questions on testing. Chris, I think probably for you. Dr. Gandalf says, when will we see updated guidance on PCR testing for Omicron dominant symptoms to protect our patients and staff over the standard 3 like shown in other countries? Something that I know you've been asked quite a bit. I guess, when does the UK definition of or criteria for diagnosing COVID align to the WHO one? And then there's a question from Julie 4D. Given the new guidance on using, this is a specific one actually, given the new guidance on using lateral flow tests towards earlier release from self-isolation when COVID positive, what's a recommendation if still positive on lateral flow test on day 11 post-isolation?
So on the, I'll take the second one first. The commonsensical answer on this is basically, if you are lateral flow positive, you are still likely to be infectious. And that's the reason, in fact, why lateral flows are really extremely useful in a sort of straight public health terms, is it is highly predictive of who is going to be infectious, both at the beginning of their infectious period and the end of their infectious period. The great majority of people, of course, will cease to be infectious in a smaller time. We know that a small minority can go out even beyond 14 days. They're a very small minority. And I think the advantage of a more test-based approach is it means more people who actually are not infectious are allowed to go about their daily lives and makes their lives easier and probably helps with adherence and a variety of other positive things. But the ones who are genuinely still excreting virus in a way that at levels which means they are infectious to others, hopefully will protect their families and their communities by remaining self-isolating until that is through. So I think that's really the commonsensical answer. I'm not sure what the official answer is, but that's certainly, if I was phoned up by a relative and they said, look, I'm still positive, what should I do? I would say, stay put. It will get back, it will go away, but I would say stay put. On the question about PCR, which was framed as if there's a right answer. There is a technical medical answer, and there is a practical answer for this. The reason we've not moved quickly on this is we have with the PCR, with the symptom issues, the usual specificity sensitivity trade-off. That the more sensitive you make something, the less specific you make it. And at a certain point, it becomes non-specific to the point of meaninglessness. And if you ask, we've got together lots of academic groups, and each of them will say, yes, there's some additional symptoms you should add, and they will give a list, but they're different lists. There isn't a consensus. I mean, obviously, individual academic leaders, and will go on the television and very, very firmly say that their list is right. But the reality is, if you take all of those, you're essentially saying anyone who feels unwell. And that gets us to a very difficult place. Now, as doctors, we all know that people can have COVID with multiple symptoms. And I think the general public knows that as well. And I think really what I would want is to encourage anybody with any symptoms that could be COVID to get a lateral flow, and then to use the PCR for people who are either unwell, are vulnerable for whatever reason, or are lateral flow positive. And this brings me to the practical reason, which is, although we have substantially increased lab capacity, actually the PCR capacity is finite, and I think that the way we're getting at the moment, if it goes up anywhere near its theoretical maximum, it will strain the system we've got very, very substantially. And what we do want to do is make sure that the people who most need PCRs are getting PCRs. And there is a real risk that otherwise we could be in a situation where people could perfectly reasonably use a lateral flow, but instead they're using a PCR in a way which is actually not likely to be terribly helpful. But if people are sick, if people have got immunosuppression, if there are a variety of other reasons people are doing it, if a GP is saying someone and they think they might have it and they would like to give a PCR for that reason, clinical discretion is built into this. Finally, I would encourage you to think through how many of your patients even know the cardinal 3 that we've currently got. If we give people a list of 7 or 8 and say, these are the things you should do, I think there's as much risk. One of our concerns is there's as much risk of causing confusion as anything else. So I'd really like to have a relatively simple thing. Particular people get PCRs, which include the 3 symptoms, but include a number of other areas. And anybody who feels unwell, or indeed is going to see someone who's vulnerable and doesn't feel unwell, get a lateral flow, because that's the thing which will help tell you, particularly whether you're infectious.
Thank you, Chris. So where does that question about diagnostic criteria fit on your ranking of questions that keep coming back to me?
Back to me? Yes. It depends. There are certain experts who go on the media who will raise them every time they go on the media. And that's fine. But the reasons I've given are the reasons that we haven't lightly thought. This has been debated endlessly in multiple groups. And the answer is, the reason we've not got to a perfect place with this is because there isn't a perfect place. All the alternative options have got downsides. They've all got some upsides, and it's always about trading those off. I think the impression that some people give that there is a single good answer, I'm afraid is incorrect technically. And that's really the problem here.
Thank you very much. David, we've got a number of questions about non-pharmacological interventions, social interventions. You mentioned earlier you thought that the public's tolerance for restrictions was higher than some people might suggest when they're interviewed, some politicians remaining nameless. A bit more detail on that. What would people tolerate? I'm not asking you to predict what might happen after Christmas, but
no, I don't know. I mean, this is why, you know, any decision in the end, the thing that stops the virus spreading is people's behavior, and that behavior may be you know, completely voluntary, just from people's own perceptions of protecting themselves and their families and their community. For example, everyone has been changing their behavior, I'm sure, just to make sure they can have Christmas together and so on. It could be, you know, influenced by guidelines that could encourage it, which are, you know, not with rules, but just advice that's been given, and that's what's being done a lot at the moment, which seems very reasonable. Or you could have actual rules which people have. But in the end, it's behavior that matters. And so it's the mechanism to induce those changes in behavior that's the vital thing. And it's quite clear that people do vote with their feet. The effect of lockdowns start before the lockdown starts, because people do change their behavior. Similarly, in the release in last July, Freedom Day, then actually people didn't change their behavior that much. Their degree of mixing didn't seriously increase. And therefore there wasn't a sudden burst. We did carry on with a long period of you know, relatively high circulation, but there wasn't a sort of splurge that many had predicted. So I'm not a behavioural expert at all. I'm a statistician. But in the end, you know, this is why, if I would want to know what's the important data, the COMIC study and other ways of identifying the amount of close contacts people have each day, just seems to be absolutely crucial in determining the future of this, of what's going to happen in this very difficult wave. But in terms of, in a way, the levers to you know, manipulate, to change that behavior, that's a big judgment, and it is a political judgment, I think, as much as a public health judgment. I'd love to know Chris's opinion on this. He knows far more than I do. I feel guilty talking about it when he's there.
Chris, David, you don't have to apologise for being a statistician. Your time has come, you know. Chris, anything to add to that?
Well, I mean, one of the many heartening things, I mean, many terrible things with COVID, but one of the many heartening things is just an extraordinary demonstration of the common sense of the general public. And if you give people clear reasons for doing something, and you're straight with them, back to David's earlier point, and you say, look, there are pros and cons and we have uncertainties, but we think on balance at this point in time, we should do this thing. The great majority of people are very supportive of that, and they want it to happen. What they want is fairness. And one of the reasons they sometimes want government to intervene is they might think, I'm going to do it, but is everyone else going to do it? And so there's also that element of it as well. But I think trusting people has almost always gone right. People are really sensible if they're given the right information.
Great, thank you very much. I think we've got time for a couple more questions. Gary, first of all, we as a college, we're hearing from some of our members that their local CCGs are really supportive of what they're doing, but we are hearing from some members who say the CCGs they're not as permissive, they're not as supportive as they were earlier in the pandemic, sometimes putting up hurdles to general practice being able to deliver the booster programme. What are you hearing?
I'm very disappointed to hear that any CCGs aren't supporting practice in the way that practice think is appropriate. As a chair of a CCG myself, I can only really comment on what I'm seeing locally. And I'm seeing my 350 staff members in my CCG equally as tired and worn out after 2 years of working in various roles at different times, being redeployed. Got a large number of staff redeployed out now into the vaccine programme. Primary care team within the CCG are working with all of the PCNs, working on the real practical logistics of how we can boost things, how we can get cover and staff shifting between different sites within a PCN. And probably most importantly is providing air cover, and that's air cover with the local population. I think the comms around what's going on at the moment is absolutely critical. I'm spending a lot of time locally trying to get the message out to the population that, you know, GPs have been asked to do something different, and that's why you can't have everything you might be expecting. We're seeing a lot of abuse directed at general practice staff, and there's a strong role for the CCGs there in helping to defend that. And and make sure that that is roundly condemned as totally inappropriate when you've got a bunch of extraordinary people doing amazing things under incredibly difficult circumstances. Business continuity planning is something we're focusing on as well. I think we're moving into a phase where we know we've got a whole host of things coming together. We've got an increased demand on services. We're working over the holiday period. We know we've got staff absences going up. We've got other staff deployed elsewhere within the system. And more importantly, for business continuity this time, supply chains and support services are also going to be struggling with staff as well. So we're spending a lot of time in RCCG asking practices to look at their business continuity plans to make sure that they're up to date and they're relevant for the next period of time. But I think the CCGs and the practices relationship will really come into its own in the next few months when this immediate sort of accelerated program of the booster is over, and we're going back to not only business as usual, but looking after the millions of people on elective waiting lists and coping with our own tired workforce and trying to give people a bit of rest. We need people to value general practice, and that's important for CCGs, it's important for NHSE, and it's important for the public. So discussions around workforce, estates, IT and workload that we're having out of the crisis period. Let's get the next few weeks over, but then let's have some really serious conversations between commissioners at local, regional and national level about what we can do to support general practice moving forward. We've shown its value in this crisis is appreciated, and we need to show the value of general practice is appreciated outside the crisis too.
Brilliant, thank you, Gary. Chris, a couple of questions. We'll make them quick ones because we've got 2 or 3 minutes left. Both hopefully quite simple ones. PPE guidance for general practice, is it likely to change? And secondly, antiviral rollout. Where are we and where are we going?
PPE is being looked at again in the light of Omicron, rightly, because I mean this does seem to be even more transmissible, and so I mean that's a UK HSA is looking at that with colleagues across all 4 nations of the UK. I'm not absolutely confident I know exactly where they're going to land yet, because we're trying to work out actually what basically changes with this and what stays the same. And what we're trying to avoid is a situation where we either underdo it or alternatively get people to do things which actually are probably largely pointless in terms of their actual risk and which are interfering with their ability to do their job. So I think it's a kind of, it's as always, it's a bit of a trade-off question. Antivirals, I mean, we're getting the first, obviously we've lost one drug as a result of Omicron for sure, which was an antibody-based drug. One of the other ones probably survives. But we've also got the oral antivirals that are coming in. Molnupiravir is starting already, and we'll have others later down the line. At least one other, probably within a couple of months, I hope, 2 or 3 months. Initially, what we're doing is we're deploying them in 2 settings for people who've got extreme vulnerability, and they're obviously very vulnerable. And even if they're boosted, they're still going to be vulnerable. And we hope, will get some form of antiviral support, whether it's antibody or drug-based. But the great majority of people, what we want to do is to randomize them into a large trial. And I would really like to promote people getting this, because the point about antivirals is you need to use them early. In contrast to the other drugs, which are we've been using things like dexamethasone, which are for late disease, the immunological area. Antivirals have to be early, so they're very much something where primary care has absolutely got to be central to getting people in. And the reason why the trials are a good way to do this is the data we've got at the moment are really from unvaccinated populations in a pre-Omicron era. So it's a way both of deploying them, but also finding out how they work under these new circumstances. So very much encourage people to take part in that. And this trial has already started, but I think will really start to take off in the new year.
Chris, thank you very much indeed. We are, I'm afraid, out of time, which is a shame because we've got lots of more questions that we could ask. Massive thank you to our panel members, to David, to Chris, to Nikki and to Gary. Thank you so much for your contributions. most importantly, a massive contribution to you who've participated in this webinar, and to everybody who's making the most amazing contribution. I've never seen a tougher time in general practice in my 30 years in general practice than we're seeing right now, but I'm not at all surprised at the amazing way in which general practice has risen to the challenge that we're facing here. So thank you to all of you for everything that you've done. Please do tell your friends about RCGP Live. They can go onto YouTube channels to have a look at this recording, to have a look at the previous sessions that we've done. Please keep an eye out for future sessions as well. It's a great opportunity to engage with your colleagues and keep yourself energized for what promises to be a pretty tough time moving forward. But thank you to everybody. I hope you managed to get a bit of a break over Christmas, and well done to you all. Thank you so much. Bye-bye.